Hello, everyone. My name is Ahmad Shawagfeh. I'm the Movement Disorder Fellow at the University of Washington. Today, I'm going to talk about an overview of deep brain stimulation in patients with Parkinson's disease. So I'm going to go through a brief history of how did the deep brain stimulation procedure or surgery develop in the last century. So in the 1940s, Dr. Russell Myers was the first to perform surgery in the basal ganglia. At that time, he found that he could reduce the tremor and rigidity of patients with Parkinson's disease in almost half of those patients without causing any significant weakness or motor deficits. And this crucial observation led subsequently to the development of all modern neurosurgery for Parkinson's disease, including the deep brain stimulation surgery. By the early 1950s, intraoperative stimulation was used to identify deep structures, such as the corticospinal tract, prior to lesioning the globus pallidus or thalamus. And in the 1960s, it was reported that high-frequency 100 hertz and above stimulation of the ventrolateral thalamus could diminish tremor in patients whether with Parkinsonian or essential tremor. By using tiny electrodes inserted deep into the brain or within the region of the basal ganglia, Dr. Hirotaro Narabayashi was able to find cluster of cells within the thalamus that fired in synchrony with the tremor of patients with Parkinson's disease. But when the levodopa was first introduced as a treatment of choice for patients with Parkinson's disease in the late 1960s, interest in surgical approaches waned dramatically. And for the next 30 years, medications dominated the treatment for Parkinson's disease. But unfortunately, patients started experiencing more of the medical therapy shortcomings, like basically the side effects, as well as not covering or controlling the symptom for a good period of time. So many people with Parkinson's disease experience the shortening of the benefit following each oral dose, which we call the wearing off phenomenon. And then many of them develop the drug-induced dyskinesias. And some people with Parkinson's disease, they have tremors that simply do not respond adequately to medications. And other patients experience intolerable side effects due to these medications. It was not until the 1990s that implantable pacemaker technology was combined with chronically implanted deep brain electrodes for long-term chronic deep brain stimulation. And that was done in France by Dr. Alim Ben Abed in the 1990s. Dr. Ben Abed and his colleagues in 1991 first reported the efficacy of ventral intermediate nucleus stimulation with implantable pulse generators, and subsequently they reported a larger series of patients with VIM stimulation for the treatment of the tremor and significant benefit in the majority of patients in 1996. These early approaches in the 1990s were followed by the development of our current state-of-the-art procedure, the deep brain stimulation, that was initially, as we stated, pioneered by Dr. Alim Louis Ben Abed in the 1990s. And then within the less than 10 years from the development, deep brain stimulation replaced the thalamotomy and pallidotomy operations. These were the early surgical operations, both of which were basically less effective compared to deep brain stimulation and carried an increased operative risk. And unlike the earlier pallidotomy or the aggressive surgical intervention, where there is permanent lesioning of the internal segment of the globus pallidus, DBS produces basically electrical effects that are largely and immediately reversible, and these can easily controlled by programming. Deep brain stimulation, typically on one side of the brain, was first approved in the United States by the FDA in 1997 for treatment of essential tremor, and it was approved for implantation on both sides in the brain in 2002 as a treatment for Parkinsonian symptoms, specifically for rigidity, bradykinesia, and dystonia, which could be an off phenomenon, a disabling off phenomenon in high percentage of patients with Parkinson's disease. This is just a quick schematic review for patient and the pathophysiology of patients with Parkinson's disease. Figure A on the right side showing basically the normal simplified circuitry within the basal ganglia, both the direct and indirect pathway, and the connection and the control over the brainstem and spinal cord. Patients with Parkinson's disease, as we know, part of the main neuropathological deficit is basically the degeneration of the dopaminergic neurons within the substantia nigra pars compacta, which means less dopamine, dopaminergic control over the D1 receptor, which are basically excitatory or stimulatory, and over D2, which are basically inhibitory, which means that there will be more stimulation of the globus pallidus external segment and less stimulation here over the GPI and substantia nigra pars reticulata. The total or the resultant effect will be basically increase in the muscle tone, slowing of the movements that we call bradykinesia, and emergence of the resting tremor. So, in theory, deep brain stimulation can be delivered to any desired brain structure. But in Parkinson's disease in general, we tend to target three targets that have consistently shown the most important anti-Parkinsonian effects. The ventral intermediate thalamus, which works best for the tremor component, but not for the rigidity or the bradykinesia. We have the subthalamic nucleus and the internal segment of the globus pallidus, or the GPI. So here, looking for the ventral intermediate nucleus within the thalamus and the subthalamic nucleus. That subthalamic nucleus location is basically inferior to the large thalamic nucleus. It's in a close proximity to the substantia nigra, mainly the pars reticulata. So it's at the junction between the thalamus and the upper portion, or the superior part of the midbrain. And we have the largest among them all, structurally is basically the globus pallidus internal segment, which basically is a more complex structure if you want to compare it to the thalamus and the subthalamic nucleus. So for the VIM thalamic stimulation, as we said earlier, thalamic stimulation works best for the tremor component of Parkinson's disease. It's basically a region under the, on the undersurface of the thalamus, and it's critical that it helps controlling most of the tremors, whether physiologic, essential, postural, or resting tremor. Electrical stimulation of the VIM part of the thalamus can almost completely and reliably stop a tremor on the contralateral side of the body. The VIM basically receives its afferent stimulation from mainly from the cerebellum, and these nuclei receive excitatory glutaminergic or glutamatergic afferents from the deep cerebellar nuclei, as well as from the cerebral cortex. And the inhibitory input, which is basically GABAergic, basically from the reticular nucleus of the thalamus. And the output from the VIM basically targets the motor areas of the cerebral cortex. But it has also been shown that it has its internal circuitry within other areas within the striatum, mainly the putamen. So thalamic stimulation on both sides of the brain will reduce tremors on both sides, as well as midline tremors, like tremors affecting the jaw, neck, and trunk. It can work for different types of tremors, whether Parkinsonian, typical Parkinsonian resting tremor, essential tremor, or even tremor caused by multiple sclerosis, which could be also including Holmes tremor and dystonic tremors. Now, patients with Parkinson's disease who undergo bilateral thalamic stimulation can experience slurring of the speech or worsening of their balance as an adverse effect. But these effects tend to reverse with adjustment in the stimulator settings, as we will talk about later on. Now, for the other target, the subthalamic nucleus stimulation, which became now the most common target that we use to manage patients with Parkinson's disease, it is the smallest structurally among all the three nuclei. It's a small lens-shaped structure, is about 6 millimeters in length. It's just right beneath the thalamus. And this nucleus, because it's small, it can be still accurately identified using mapping techniques, and usually the DBS passes through this target, the electrode. It's a very crucial and important node in the basal ganglia circuit, and it's basically a major target for cortical afferents and other inputs from other basal ganglia components. It receives its excitatory afferent from the frontal lobe of the frontal lobe of the cerebral cortex, basically mainly the motor area and the supplementary motor area. And its inhibitory input comes from the globus pallidus external segment as part of the indirect basal ganglia pathway. And the excitatory afferents basically also can come from the parafascicular nucleus of the thalamus, which is a major component of the intralaminar nuclear group of the thalamus. There are also inputs from the pedunculopontine nucleus, which became within the last few years an area of interest. This particular nucleus, because it's an cholinergic nucleus within the pons that's been shown that it plays a crucial role in gait disturbances and abnormalities in patients with Parkinson's disease, and it's now currently being studied as a target for deep brain stimulation, mainly for the gait component and the postural instability in patients with Parkinson's disease. Also, the subthalamic nucleus receives afferents or input from the substantia nigra pars compacta. The major output of the subthalamic nucleus, which is excitatory, glutamatergic, goes to both segments of the globus pallidus and to the substantia nigra pars reticulata. In addition to reciprocal connection to the pedunculopontine area. Now, it's been neuroscientists trying to understand the different clusters of cells within the subthalamic nucleus. It seems like there are different types of clusters of nuclei within this, or neurons within this small nucleus, but so far the classification schemes have not agreed on how many types of neurons exist within the subthalamic nucleus. Now, stimulation of the STN, in contrary to the VIM, it has a broad anti-Parkinsonian effect. It can improve not only the tremor, but also the bradykinesia, the rigidity. It can also reduce the intensity of the dyskinesias, speech to some extent, though it can also worsen the speech. It can improve the handwriting and the dystonia. The anti-tremor effect of the STN stimulation is comparable to that of the thalamic VIM stimulation. And now it's considered to be the most effective surgical intervention for Parkinson's disease patient. And in carefully selected individuals, STN stimulation can reduce Parkinsonian symptoms in the unmedicated state by 30 to 60%, as measured by the standard rating scales like the UPDRS-3 and the PBQ-39. Many people with Parkinson's disease find that they require less anti-Parkinsonian medication after STN stimulation. And some of the patients, and we have experienced this on clinical basis, that they can actually stop taking their medication altogether. And as a result of the reduced amount or the reduced need of medication, in addition to the direct stimulation effect, there might be dramatic reduction or even elimination of the side effects of these medications, and like dyskinesias. But overall, the beneficial effect of the STN stimulation generally parallel those of levodopa, but do not surpass the best result of the medication treatment. The third target, which is the globus pallidus stimulation, we're talking about the internal segment, the GPI, which is basically the postereventral medial globus pallidus. And this used to be the site for pallidotomy operation, and it represents the main outflow connection from the globus pallidus to the thalamus. The globus pallidus is the largest among all these three targets, and it has more complex structure than the STN, and it has a complicated internal circuitry. And because the globus pallidus is so large, the entire deep brain electrode resides within it. as contrasted to the STM. It is now the second most commonly used DBS target for treatment of Parkinson's disease, but still it's the primary target for treatment of dystonia. And even if patients with Parkinson's disease who have their predominant off symptoms or fluctuation symptoms manifesting as painful off dystonia, we prefer to use GPI over STN as a primary target. The GPI is one of the primary output nuclei of the basal ganglia and is considered the main output representation of the limb movements. It receives its excitatory glutamatergic afferents from the STN, as well as inhibitory input or afferents from the striatum, and inhibitory inputs also from the globus pallidus external segment and nigral dopamine afferents. The output from the GPI is mainly inhibitory through GABAergic output to the VA and VL thalamic nuclei, in addition to the intralaminar nuclear group within the thalamus and the pedunculopontine area. Now, based on the afferent and efferent connection of the globus pallidus, it's been argued that the reduction in dyskinesias following GPI stimulation is basically a direct effect of the procedure and the stimulation itself. Whereas patients who undergo STN stimulation, the dyskinesia is basically improved because patients usually require less medication. So they have less side effect from the medication and hence less dyskinesias. So after talking about these three targets, if we want to refer a patient with Parkinson's disease for DBS or consider DBS, how do we proceed with this? First of all, DBS is not a surgery for every Parkinson's disease patient. It's not for everyone. Overall, we think the best candidate for deep brain stimulation is a patient with Parkinson's disease who have the disease for 10 to 20 years and who experiences wearing off motor fluctuations with episodes of extreme bradykinesia slowness, stiffness, and tremors that's caused by failure of medication doses and significant dyskinesias. The effect of DBS, we usually, when we discuss this option with patients, we want to make it clear for the patients that the DBS effect tends to parallel the best results of the individual doses of the medication. But in certain group of patients with Parkinson's disease who have tremor predominant Parkinson's disease that's severe and it's medication resistant, this is also a subgroup of patients that they still could benefit from DBS. Patients with Parkinson's disease who are younger and whose primary problems are basically tremor predominant and they're having a lot of dyskinesias, a lot of on-off fluctuation, tend to have better results than older people with Parkinson's disease who tend to have more of the speech, balance, and gait freezing spells and problems. This is also a simplified table for patient selection. The good candidates for DBS, basically typical Parkinson's disease, asymmetric, tremor predominant Parkinson's disease with good response to individual doses of levodopa. They have significant amount of fluctuation with on-time dyskinesia, significant wearing off spills, good general medical health, and excellent family support with good psychiatric history, means that they don't have significant depression or other psychotic illnesses. While patients with atypical Parkinsonian syndromes like progressive supranuclear palsy, multiple system atrophy, corticobasal ganglionic degeneration, or vascular Parkinsonisms, this group of patients tend to be poor candidates for DBS. Patients with poor response to levodopa are also poor candidate. Patients with significant cognitive problems, memory problems, apathy or confusion, severe depression or anxiety, severe comorbid medical illnesses, as well as lack of good social support. Another relative contraindication or poor candidacy for DBS if autonomic symptoms are predominant in patients with Parkinson's disease. Typically, we start seeing autonomic dysfunction in patients with idiopathic Parkinson's disease with long-standing disease for more than a decade or sometimes 1.5 or 2 decades. And usually these symptoms do not respond to DBS and might even get worse. So in general, candidates who will most likely benefit from DBS, typical classic Parkinson's disease with tremor at rest, rigidity, and bradykinesia, symptoms that still respond to individual doses of the anti-Parkinsonian medications, even if the response is brief, with disabling Parkinsonian symptoms in the off state and uncontrollable medication-induced dyskinesias. The presence of severe rest tremor, the good understanding of the potential benefits and risks from the operative procedure and evaluation, and the ability to give informed consent, good general health, good emotional support network of family and friends. While patients who would not likely benefit from the DBS, again, atypical or rare forms of Parkinsonism, as we said earlier, PSP, MSA, corticobasal ganglionic degeneration, acquired causes of Parkinsonism due to stroke or previous history of brain injury. Also, patients who fail to experience any benefit from anti-Parkinsonian medications will likely not benefit from, mainly we're talking about rigidity and bradykinesia, will less likely get benefit from the DBS. Still, again, as we said earlier, a subgroup of patients who have severe resting tremor that does not respond to levodopa or dopaminergic medications still can be considered for deep brain stimulation. Patients with significant cognitive issues, confusion, hallucinations, psychotic features, also these things tend to get worse after deep brain stimulation. The presence of significant gait abnormality in the form of freezing, balance problems, frequent falling, these might get worse, especially after bilateral subthalamic nuclear stimulation, severe chronic psychiatric illnesses like psychosis, depression, bipolar disease, alcoholism or personality disorder, and the inability to understand the potential benefits and risks of the operative procedures or to give an informed consent. Also, the presence of significant medical comorbidity that can increase the surgical risk. Note that in general, age is not an essential criterion for surgery, though in general, younger patients, due to better overall health, tend to respond better to deep brain stimulation compared to elderly patients. In general, handwriting might improve. Speech might get better and walking might get better, but this is not one of the things that we target with deep brain stimulation because speech and gait, again, might get worse. Some people who with PD who undergo DBS surgery might experience a significant improvement in sleep quality, and weight gain is one of the things that patients, even without increased appetite, might also happen after the surgery. Another form of fluctuations other than the motor fluctuations that patients with Parkinson's disease might experience, non-motor fluctuations, that during wearing off spells, they might suffer from episodes of anxiety, depression, bladder or bowel impairment, painful sensation that does not correlate with dystonia or cramps. These things might not improve because it's unclear whether DBS can relieve these distressing symptoms. So in general, DBS helps with tremor, rigidity, the hand function, improving the dyskinesia and the wearing off spells, while in general does not help the freezing, the backward falling, the tachyphenia, which is basically the festination form of speech, the posture, the dementia or the apathy, anxiety, or the depression. So before proceeding with the surgery, the patients with Parkinson's disease and the family should be basically educate themselves and be educated about the procedure. Deep brain stimulation is always an elective procedure, and ultimately the decision to proceed must be basically of the person with Parkinson's disease. He or she should basically read the available literature and become familiar with the practical aspects of deep brain stimulation. It can be helpful and reassuring to meet someone who has already gone through the experience, and of course the person with Parkinson's disease and family must meet the neurosurgeon performing the procedure. Then after detailed discussions with the treating neurologist, the surgeon, the patient must undergo the preoperative screening test. And this includes basically getting a baseline brain MRI. It hasn't been done, making sure that the patient doesn't have a structural pathology that might warrant further investigation or might be a contraindication to find a stroke or a tumor that might prohibit proceeding with the procedure. General medical examination, and as neurologists, we perform the on-off testing, which is basically trying to examine the patient while he's off the levodopa or his dopaminergic medication. We usually typically bring them on in the morning, ask them not to take their medication overnight. So to see them at their worst, we do the neurological examination. We usually quantify the deficits or the degree of the tremor, the speech, the facial hypomania, the rigidity, and the bradykinesia using the Unified Parkinson's Disease Rating Scale, Division 3. And then we ask the patient, after we're done with the examination, to take their regular dose of the dopaminergic medication or the carbidopa, levodopa, and ask them to come back after an hour and repeat the examination. Usually it takes 30 minutes. If the patients take the medication on empty stomachs, it takes 30 minutes, 40 minutes for the medication to get absorbed. So typically to make sure that the medication has kicked in, we bring them like an hour after they take the medication and repeat the examination. And then by comparing the score while they're on compared to their off, we determine how much response they get from the medication. So we know, or we can basically anticipate how much benefit they're getting from the DBS. Usually scores improvement or reduction in the score on the UPDRS-3, more than 30%, indicates good response to deep brain stimulation. Neuropsychological testing is an important test, evaluating for how significant the cognitive function. Basically, some institutions refer patients for baseline speech and swallowing evaluation. As we said, this particular part might get worse after deep brain stimulation, especially bilateral STM. Taking good psychiatric history from the patient, especially if the patient has major depressive illness, any suicidal thoughts and ideation, especially if the patient is going for bilateral STN, because as we're going to talk later, STN has shown in some studies that it might actually increase suicidal ideation in Parkinson's disease patients. So going to the surgery itself. So this is the deep brain stimulation from courtesy of Medtronic. This is the implantable pulse generator or the battery. There are different types or models, Solitra, Kinetra, and Activa. And we have basically the DBS or the connecting wire. And then we have the electrode that passes through the target. The deep brain stimulation lead, at the very end, it has 4-point contacts, basically, that we use to program the patients by trying to find the best combination with the least side effect to control the tremor and improve the bradykinesia and the rigidity. So the DBS lead is an insulated wire with 4 contacts at its end that we use to combine for the programming, and the connecting wire, which runs under the skin from the DBS lead, the scalp side, behind the ear, down to the neck, into the chest, and basically connects to the battery pack or the IPG, the implantable pulse generator. And the implantable pulse generator resides like a pacemaker just beneath the skin in of the chest, under the clavicle, typically the left side. Sometimes patients can have, like for each side, 2 different batteries or 2 different generators, sometimes 1 generator for both sides of the brain. The successful outcome and the risks of the procedure depend critically upon accurate targeting. Usually, the surgery starts with placing the head frame that's attached to the skull, getting the MRI imaging for brain mapping, performing a pair hole under local anesthesia, then electrophysiologic brain mapping using microelectrode, basically to try to find the target, the STN, the VIM, or the GPI, and then the deep brain stimulator electrode is inserted in the brain. Now, this part basically, whether under local anesthesia or general anesthesia, depends on the expertise of the neurosurgeon. Some neurosurgeons prefer to do the procedure under general anesthesia. Some they like to perform it under local anesthesia, especially patients with tremor predominant, whether Parkinson's disease or essential tremor, because at the same time they can do some programming with microelectrode stimulation, and they can find if they are, by doing some stimulation intraoperatively, if they can control the tremor, because this helps them know if they are actually within the target. Now, placing the battery back, sometimes some neurosurgeons prefer to do that the same day, but most of them, they prefer to do that a week later. Like every surgery, there are risks. The risks from DBS can be divided into hardware risks, immediate surgical complication risks, and stimulation-related risks. The potential complications can range from just mild headache or drowsiness to more serious or reversible effects like infection, stroke, or hemorrhage. These patients might experience post-operative sleepiness, disorientation, slowing of mental processing, hallucinations, poor motivation, or depression. But these usually are transient for 1 or 2 days. Patients specifically who undergo bilateral subthalamic stimulation can have difficulty opening their eyes, eyelid opening apraxia. And in medical centers that they have the most experience with DBS, the risks from the most serious complications, basically stroke or bleeding, is usually less than 5% per stimulator placement. Typically, with literature review, it's stated that the risk of intracranial hemorrhage or clinically significant intracranial hemorrhage is less than 3%. Individuals are often asked, so during the surgery, and again, this depends on the neurosurgeon expertise, patients are asked to withhold their medication. The same way that we do the on-off testing for preoperative evaluation, the neurosurgeons might ask the patients to hold their medication several hours or the night before, so that when they go with the electrode placement and start doing their microstimulation, they won't have any basically false positive or negative interference from the dopaminergic medication. When we start, the other set of the complications of the third surgery are basically the stimulation-related side effects, the things that we induce to the patients whilst doing the programming procedure itself. The most common of them is basically sensory symptoms, whether it's electrical stimulation, numbness, or tingling, that mainly involve the face or the hand. It can also induce some feeling of dizziness, lightheadedness, balance issues. Sometimes we can induce using high voltages, high frequency, or pulse width, induce dyskinesias, muscle spasms. Also, mainly it affects, when they happen, they affect the face and the hand. Slurring of the speech, diplopia, and worsening mood also can happen, and these can be also adjusted by adjusting the DBS stimulation parameters. Now, for the GPI, as we said earlier, the GPI stimulation for Parkinson's disease, it helps with all aspects, resting tremor, bradykinesia, as well as with the rigidity, including the reduction of the dopa-induced dyskinesia. So the GPI is believed that the structure itself has an anti-dyskinetic effect when you stimulate the GPI. But typically, GPI does not permit reduction in the medication. So if the patient has significant side effects or limitation from the medication, like orthostatic symptoms, psychosis, daytime lethargy, or cognitive impairment related to the dopaminergic medication, then GPI might not be a good target, because typically with GPI, we don't see significant reduction, or does not allow us to significantly reduce the medication dosage. While STN-DBS provides similar reduction of motor symptoms, several studies indicate that bilateral STN can improve gait tremor and bradykinesia, but also it permits the reduction of dopaminergic medication, leading to fewer drug-induced adverse events. And with a few direct and controlled comparisons of GPI-DBS and STN-DBS, the preliminary report of the controlled comparison of the benefit confirms that the clinical benefit is comparable at either site, with little change in the preoperative medications in the GPI group as opposed to the STN. The degree of the benefit from the STN-DBS or GPI-DBS does not usually exceed that found from individual doses of levodopa in each patient, but DBS affords two main advantages. It reduces the time the patient spends in the off state when the benefit from the individual dose of the medication has diminished, and it permits the reduction of medications and their attendant untoward effects, and mainly with the STN. The benefit from the surgery, the DBS, appears to be sustained, a range of 3 to 5 years, although some complications appear to be cumulative. Several studies have demonstrated an improved quality of life from STN-DBS. Cognitive impairments such as disorientation or memory deficit might be exacerbated by DBS and is a relative contraindication for the procedure. Interestingly, the STN-DBS in particular might impair particular part of the cognitive function, which is mainly the visuospatial spatial processing. The stimulation settings optimized for motor benefit may also impair spatial delayed recall or response inhibition, and others have found that STN-DBS might improve some of executive functions, whereas GPI-DBS might produce deleterious effects. However, relatively simple cognitive tasks may be unchanged or improved by STN-DBS, whereas more difficult, demanding tasks could be impaired. And socially important activities such as identification of the emotional tone of an angry face may be also impaired. STN-DBS might also produce undesirable emotional responses, including manic responses, hallucinations, and decreased mood, and yet at other times might provide an antidepressant effect in some other studies. This is one of the earliest studies that have been done in the last decade, a randomized trial of deep brain stimulation of Parkinson's disease that was done in 2006, published in the New England Journal of Medicine. In this study, 156 patients were enrolled with advanced Parkinson's disease and severe motor symptoms. And in this study, the primary endpoints were basically to assess changes from baseline to 6 months in quality of life, assessed by the Parkinson's Disease Questionnaire, PDQ-39, and the motor symptoms assessed by the UPDRS-3. And pairwise comparison showed that neurostimulation group, as compared to the medication alone group, caused greater improvement from baseline to 6 months in the PDQ-39, 50 out of 79 pairs, and the UPDRS in 55 out of 78 pairs, with a mean improvement of 9.5 points and 19.6 points respectively. The neurostimulation group also resulted in improvements of 24 to 38% in the PDQ-39 subscales for mobility, activities of daily living, emotional well-being, stigma, and bodily discomfort. Serious adverse events, though, were more common in neurostimulation than the medication alone, 13 to 4%, and this included a single case of fatal intracerebral hemorrhage. The other study that was published a few years ago, and it was conducted to compare GPI versus STN stimulation for patients with Parkinson's disease, and that was done at 7 veteran hospitals and 6 university hospitals. Actually, the Seattle Puget Sound VA hospital was among the hospitals involved or contributed to the study. 299 patients with idiopathic Parkinson's disease were randomly assigned to undergo either pallidal stimulation or subthalamic stimulation, and the primary outcome was also blindly assessed using the UPDRS-3. while patients were receiving just stimulation but no anti-Parkinsonian medications. And the secondary outcomes included self-reported function, quality of life, neurocognitive function, and the presence of adverse events. The mean change in the primary outcome did not differ significantly between the two studies. There was also no significant difference in self-reported function. But patients undergoing subthalamic stimulation required lower dose of dopaminergic agents than did those who underwent pallidal stimulation. One component of processing speed, the visual motor or the visual spatial, declined more after the subthalamic stimulation, more than the pallidal stimulation. And the level of depression basically worsened after subthalamic stimulation and improved after pallidal stimulation. Adverse events occurred in 51% of patients undergoing pallidal stimulation and 56% of patients who underwent subthalamic stimulation, but there was no significant in-between group differences at 24 months. And in regards of stimulation settings at 24 months at the end of the study, the average stimulation amplitudes differed significantly between the two groups, meaning that the patients underwent pallidal stimulation have to have higher voltage compared to patients with subthalamic stimulation. Same thing with the pulse width, but the frequencies did not differ significantly between the two groups. As we said earlier, the use of dopaminergic medications decreased in this study in patients undergoing subthalamic stimulation compared to pallidal stimulation at 24 months. On average, pallidal group, they were requiring 1,118 milligrams of levodopa or its equivalent on a daily basis, while on the subthalamic group, they were requiring 887 milligrams, or its equivalent of the levodopa, with mean or the average difference of 165 milligrams daily of levodopa. Now, it has been always a question because, as we said earlier, that typically we refer patients with Parkinson's disease who have the disease for a decade or two, but a study that has looked about neurostimulation for Parkinson's disease with early motor complications, early STEM, that was conducted in Germany and France. And in this two-year trial, 251 patients with Parkinson's disease who developed early motor complications with a mean age of 52 years and the duration of the disease around 8 years, 7.5 years, were randomly assigned to undergo either stimulation plus medication or medication alone. And the primary endpoint was assessed using the UPDRS and the PDQ-39. Sorry, using the PDQ-39 summary index. And the major secondary outcomes, including Parkinsonian motor disability, were assessed using the UPDRS 3, 2, and 4. And for the primary outcome, quality of life, the mean score for the neurostimulation group plus medication improved by 7.8 points, and that for the medical group worsened by 0.2 points. The neurostimulation was superior to medical therapy with respect to motor disabilities, activities of daily living, levodopa-induced motor complications, and the time with good mobility and no dyskinesias. Serious adverse events were more in the 54.8% in patients who underwent stimulation compared to 44% in patients who were just getting the medical therapy. Serious adverse events related to surgical implantation or neurostimulation device occurred in 17.7% of patients. So overall, the advantages of the deep brain stimulation, it avoids the adverse side effects from permanent lesioning procedures. So it's basically replacing the old surgical procedures of pallidotomy or thalatomy, because these are reversible lesioning, and whatever adverse effects happen affecting the gaits, the speech, or the swallowing function, it's irreversible. The effect of the stimulation, if the patient develops electric neurological complication related to the stimulation itself, this can be easily adjusted and reversed. And again, it's easily adjustable by adjusting the stimulation parameters to optimize the clinical benefit. It can be safely performed in patients bilaterally in contrast to ablative procedures. And it might be the only, so far, the only effective treatment that we have to treat or manage levodopa-induced dyskinesia. And the benefit from the surgery tends to be long-lasting. While disadvantages of the DBS can include complications related to the surgery itself, including intracranial hemorrhage, tends to happen in less than 3% of the patients. Also, to less extent, around 1% or less than this, pulmonary embolism, hematomas, venous infarction, and seizure. Hardware related to failure, like lead extension fracture, migration, presence of short or open circuit, or malfunction of the pulse generator, infection, etc. And the adverse effects of that are related to the stimulation itself, basically the presence of, as you deliver electrical current, mainly if you're using high voltage, long pulse width, or high frequency, it can spread to adjacent structures, leading to tonic muscle contraction if you spread to the posterior limb of the internal capsule, dysarthria, paresthesia, also due to extension to either the VPL or VPM nuclei of the thalamus, or even the posterior limb of the internal capsule, and worsening of the akinesia. Worsening of akinesia in patients with subthalamic nucleus, would you think that there might be an extension, because it's a small target, to the substantia nigra pars reticulata or compacta, which is basically just a few millimeters inferior to the subthalamic nucleus. Other adverse effects: weight gain, dyskinesias. These dyskinesias can be adjusted by basically trying to lower the settings. Axial symptoms, in terms, basically there might be a worsening of the gait or postural stability. Eyelid opening apraxia, diplopia, visual depth perception difficulties, tonic muscle contraction, dysarthria, sometimes worsening of the behavioral or cognitive function. Long-term complications: it's an implantable device. There is always a risk of infection or erosion. Patients, now the question of developing tolerance DBS, it's a question of debate, a matter of debate. It's most because we know that DBS is not a cure and does not affect the actual progression of this neurodegenerative disease. As the disease progresses, patients might require higher settings for better control of their symptoms, and we always keep the patients informed that this procedure is not a curative procedure, and it has its own benefits, and the benefits might not be long-lasting. Development of dementia, as we said, it's not that it triggers causes dementia. It's basically that it can worsen certain aspects of the cognitive function. And the STN, the most prominent one was according to studies, was the visual spatial perception, and sometimes sudden loss of affect. Okay. Any questions?
So it seems like medical comorbidities aside,
yes,
really the only question in terms of being a good candidate for the surgery is how long we've waited in the disease course, right?
Yes.
Because the symptoms that don't respond well, looks like, are just the ones that are sort of the end of the Parkinson's disease course. So I guess my question is, why do we wait until people have these wearing off effects to do the surgery?
So good question. The thing that patients with Parkinson's disease tend to be reluctant in going through the procedure early. They always prefer to go through the medication. And most of the patients with idiopathic Parkinson's disease, they have a good response at the early onset, at the time of onset, to levodopa, carbidopa-levodopa, or other dopaminergic medications, whether talking about the rigidity, bradykinesia, or the resting tremor. So when they see this substantial, significant improvement on the medication, they tend to be reluctant on doing an intensive aggressive surgery like deep brain stimulation. Okay, but again, this is a question of debate. Studies like the one that I showed you, the early STEM study, looked at basically patients with early onset motor fluctuation, and it showed that actually doing the surgery early also provides benefits that's comparable to medication. Okay, medication alone, and medication plus the deep brain stimulation is better than medication alone. So if the patient agrees on if you go through the process and the patient agrees going through the deep brain stimulation, let's say the patient has symptoms just for a few years, okay, but he's having the on-off fluctuation, and you think he's fulfilling the criteria for DBS, he's a good candidate, it's something that you can proceed. with the procedure, taking into consideration benefits versus risks. And even risks, like talking about worsening, there are three main things that we keep in our mind when we talk to patients and discuss DBS, basically gait, speech, cognition. Young people, they don't usually have these problems, whether with idiopathic Parkinson's disease or, yeah, so.
Right. Yeah. It just seems like this isn't a disease where we say we don't know exactly what's going to happen. We have an excellent time course development. Eventually certain things will happen. So
typically, idiopathic Parkinson's disease is a slowly progressive disease. This is the typical course of the disease, and DBS won't make it quicker, the progression, or slower. It's the same way that you're using a medication, symptomatic treatment.
Am I correct in that quick device question? Are all the pulse sequences inhibitory by definition?
From the DBS itself?
Yes.
We don't know the exact mechanism, how the pulse or inducing the electrical stimulation.
How fast is the stimulation train? Because you gave the length of the stimulation, right?
You mean the frequencies in patient?
Right.
So the frequencies that we use for patients with Parkinson's disease to control the tremor can range anywhere from 60 to up to 185, rarely to 210 hertz. Yes.
Okay.
So there is a big range from 60 up
It just
to.
seems like you'd be saturating your circuit and probably getting past the refractory period.
Yes. But I mean, it depends on how because frequency per se is the one that helps. If the patient has tremor resistant and you're on relatively high voltage, or so the second thing that you do after adjusting the voltage is going through frequency, and it seems like the frequency is the one that helps most the patient with tremor. Yeah, but from personal experience, most patients you get good control of the tremor at range between 90 to 150. Okay, rarely at 60, but sometimes I didn't see any patient that we need to go like to 210 or something like that.
Do any of the electrodes record, or are they all only stimulating electrodes? Can you get recordings out of these?
You mean like what electrode combinations? Or?
Yeah, you've got a wire in there, right?
Yes.
Can you actually take signal off of that wire and transduce, neural activity if this system isn't stimulating, for example? We have atrial sense V-paced cardiac devices, for example. Is there anything similar going on in this circuit? Or could there be?
No
one's sensing out of this. Okay.
Yeah.
Fair enough.
Quick question. I think you said that typically the duration of success with the deep brain stimulation is about 4 years.
On average.
Is that what you see in clinic? I mean, is that just what's been studied, or is that what you actually see in clinic, like the people can?
No, we've seen patients that they have the DBS for almost 10 years and they're still getting benefit from the medication. Okay. This is what the studies have shown. But no, yes, we've seen patients who had this DBS for almost a decade and they still have benefit controlling their tremor. But then we still, after 10 years, and in some patients, we don't have to change the parameters. We see them on follow-ups like every 6 months or every year or once every 2 years, and we don't have to change the settings. Then we ask ourselves, is this due to the stimulation itself, or is there a lesioning effect from the electrode that has just healed, and then the patient developed a gliotic lesion, and it's like we're converting from DBS stimulation to pallidotomy.
What's the latest with MRI compatibility?
Oh, thank you for this question. It depends. If you go through the Medtronic website about compatibility, it depends on the model. Is it Kinitra, Solitra, or Activa, and the number of the model, basically, because some of the models are basically just head MRI compatible. Some of them are whole body compatible. Okay, but there is also a long list of checklists to things go through. The DBS needs to be basically interrogated before going to the MRI if it's compatible, making sure that there is no open or short circuitry within the MRI, within the DBS. Okay, and based on that, and based on the original, basically, if the implantable pulse generator or the DBS is full body or head only compatible, then it can proceed. Some of them, they are not compatible with MRI at all. So since the procedure is elective procedure, if the patient needs we anticipate that he might need surgical intervention. Let's say that the patient has, for example, a radiculopathy, cervical or lumbosacral radiculopathy, and he needs a surgery and he needs an MRI before the surgery, we usually typically ask them to get these studies done before doing the MRI, basically. But it still could be compatible, but now we need to have like a radiology department that are comfortable dealing with patients with DBS, because the DBS needs to be most probably turned off before proceeding with the procedure, and this can cause basically worsening of the symptoms. It's worsening of the symptoms can be immediate and very uncomfortable for some patients. Some patients can tolerate going for an MRI for 45 minutes, an hour or so. Some of them they can't. And the magnetic, there are different types of magnetic fields, static as well as gradient magnetic field, and the other radio frequency type of magnetic fields. Every one of them has different effect on the DBS, whether by causing just thermal effect, increased heating, causing tissue injury, and some of them just cause unwanted stimulation of the electrode that can either increase or decrease some of the settings, or even sometimes turn off the DBS. And even if you turn off the DBS and send the patient to the MRI, it might turn it on. So
this is way too complicated, it sounds like, for the average neurologist. Who do we call in these situations to figure this all out?
So it should be both the movement disorder specialist or the neurologist and the radiologist. Yes.
What other kind of general activity restrictions do these patients have once they have a DBS in place?
General activity, in general, there is nothing in particular that we ask the patients not to do in terms of physical activity. Of course, the patient will have the lead going down. Okay, so basically excessive neck extension, flexion, all this stuff might lead to misplacement, migration, or breaking. Okay, but this is just with aggressive form of activity, or let's say a patient is a boxer or something like that. This might get broken. Okay, with the aggressive activity, and we always sometimes patients for some reason undergo some thermal electrocauterization or thermal therapy for relaxation, but with extreme degrees of heat. Okay, this can basically cause some thermal injury within the DBS leads. I have not that good vision. I don't know if there are any questions over there. Any other questions?
Thank you.
Thanks.